Hepatocellular carcinoma. Hepatocellular carcinoma is a primary malignancy of the liver and occurs predominantly in patients with underlying chronic liver disease and cirrhosis. The cells of origin are believed to be the hepatic stem cells, although this remains the subject of investigation. Tumors progresses with local expansion, intrahepatic spread, and distant metastasis. HCC is now the third leading cause of cancer deaths worldwide, with over 5,000 people affected.
The liver is the largest organ inside the body and is located just below the ribs on the right side. The liver has many functions. It filters waste and other harmful materials from the blood. It produces enzymes and bile that help with digestion. And it produces chemicals and hormones necessary for regulating many body functions. Liver cells are called hepatocytes. Liver cancer is classified as either primary, starting in the liver, or secondary, spreading to the liver from cancer in another part of the body. Hepatocellular carcinoma is the most common form of primary liver cancer. It develops in the liver cells and damages other healthy liver cells. Continuous growth of cancerous hepatocytes can cause malignant or cancerous tumors to form. In its early stages, liver cancer does not produce many symptoms and is hard to detect. As the cancer grows, symptoms such as abdominal pain and bloating, weight loss, nausea, vomiting, fatigue, and jaundice or yellowing of the skin and eyes may appear. While doctors do not know exactly what causes liver cancer, chronic liver infections such as viral hepatitis B and C and cirrhosis of the liver can increase a person's risk for developing the disease. Men are more likely to develop liver cancer, as are people over the age of 60. There are different treatment options available depending on the type and stage of the cancer. Surgery or a liver transplant are options only if the tumor is small and contained within the liver. If the tumor is very large or has spread beyond the liver, chemotherapy or radiation may relieve symptoms and prolong life, but this is not a cure.
Applications in medicine. No effective systemic therapy exists for patients with advanced hepatocellular carcinoma. A preliminary study suggested that the sorafenib, an oral multikinase inhibitor of the vascular endothelial growth factor receptor, the platelet-derived growth factor receptor, and RAF, may be effective in hepatocellular carcinoma. In preclinical experiments, sorafenib had anti-proliferative activity in liver cancer cell lines, and it reduced tumor angiogenesis and tumor cell sign lining and increased tumor cell apoptosis in a mouse xenograft model of human hepatocellular carcinoma. These trials showed that there was no significant difference between two groups in the median time to symptomatic progression, 4.1 months versus 4.9 months, respectively. The median time to radiologic progression was 5.5 months in the sorafenib group and 2.8 months in the placebo group. No patients have had a complete response.
The treatment options for advanced liver cancer are limited, and the only FDA-approved medication in the U.S. is sorafenib, which is a multikinase inhibitor for patients with advanced disease. There was a trial in 2008 that was published in the New England Journal that resulted in the approval of this medication for advanced liver cancer. The trial included patients with very well-compensated liver disease and good performance status, and it showed a survival benefit. There's limited real-world data for this medication and its efficacy and patients with advanced liver cancer. So what we aim to do is look at SEER Medicare, which is a large national data set in the U.S. that has cancer diagnoses, including Medicare claims data, comorbidities, to try to understand what the real-world benefit of sorafenib is in advanced liver cancer, and some mitigators of that benefit, or what are some factors that influence that. So we had 228 patients that were treated between 2007 and 2009 with sorafenib therapy, versus 870 patients with advanced liver cancer that had no treatment. So we had a comparison group to compare to. And we looked at the survival benefit of sorafenib treated patients versus the control patients. We found that patients that were treated with sorafenib had a survival benefit about 88 days compared to untreated patients, which is consistent with the clinical trial data. Significantly, the major liver societies, including the ASLD, recommend therapy with sorafenib for patients with Child's class B cirrhosis, which indicates they have some sort of decompensation. So we were specifically interested in that population because there's not very much limited data on seeing what the survival benefit is in that population of patients. So we had coding for patients with decompensation, which includes ascites, esophageal varices, and hepatic encephalopathy. And once you had a decompensation, that survival benefit decreases down to about 31 days versus 88. So the survival benefit is diminished significantly once the liver is sick, which is maybe consistent with what we see with clinical practice. And the strength of this study is that we have a comparison group to compare that to. So there's about 86 patients in our cohort with decompensation, and we compare that to control patients with decompensation. That's how we derived our survival benefit. And so that was the rationale and the results of our study.
When the disease is detected at early stages and is amenable to potentially curative treatment, surgical therapies such as resection or liver transplant, and locoregional procedures like radiofrequency ablation, these can be options. 5-year survival rates of up to 60 to 70% can be achieved in well-selected patients. However, disease that is diagnosed at an advanced stage or with progression after locoregional therapy has a dismal prognosis, owing to the underlying liver disease and lack of effective treatment options.
This is a video of an ultrasound-guided percutaneous radiofrequency ablation, or RFA, on a patient with primary liver cancer. Diagnostic CT shows a 16 millimeter large tumor located centrally in the liver. Here is the same tumor located with ultrasound. The radiologist maps the blood vessels in the liver and plans a path for the RFA needle. The needle is attached to the ultrasound probe and inserted into the liver and tumor. Here we see the needle in place in the tumor. The needle has an outer sleeve and an inner movable part. When the radiologist pushes the inner part out, 10 tines expand like an umbrella in the tumor. Here is the needle with the tines expanded. The ablation can now start. The patient has 2 electrodes attached to each thigh. When the RFA needle is connected to an alternating current generator, an electric circuit is established through the patient. The liver tissue is heated 2 times for 5 to 10 minutes. Friction heat energy is created around the needle. This leads to necrosis of the tumor and a brim of healthy liver tissue around it. The ablation creates bubbles in the liver tissue, which conceal the tumor. These bubbles disappear after about 10 minutes. The radiologist can then do a contrast-enhanced ultrasound to control that the necrosis is of an adequate size. Here we see the diagnostic CT image again. And here is a CT scan taken the day after the RFA treatment. Here is the resulting necrosis around the tumor and in the needle canal.
So it's a titanium pump. It's about the size of a hockey puck.
A hockey puck shaped device that's improving the quality of life for patients with liver cancer.
And what this is an implantable device that goes under the skin with a long tube that goes up into the artery that feeds the liver. And the purpose of that is to be able to trickle very high doses of chemotherapy directly to the tumors in the liver without many side effects of the chemo going throughout the body.
The pump delivers 400 times the dose of chemotherapy directly to the liver, leaving the patient with no side effects.
Nationwide, there's not a lot of people that are placing these pumps. Nobody else in the state of Florida are doing them currently. So it is something fairly new to the area to provide more options.
The pump is the size of a hockey puck that sits just beneath the skin near the abdomen and pumps chemotherapy directly into the liver.
Most commonly, we use it for patients who've had colon and rectal cancers that have spread to the liver. That's the more common scenario. It's the most common organ to have cancer spread to.
In addition to the pump, patients may have part of their liver removed to minimize the risk of the cancer coming back.
The reality is these patients are living a long time and they get tired of being on chemotherapy. They want a break. So if they have disease confined to the liver, this provides another step for them to maybe get off of chemotherapy altogether for a period of time.
While it's not a cure, it offers patients another option of treatment to help prolong their survival rate. For Lee Health, I'm Lindsay Fry.
The pros. In this trial, patients with advanced hepatocellular carcinoma who received sorafenib treatment had nearly a 3-month median survival benefit, as compared with those patients who received placebo. The cons. Adverse effects such as diarrhea, weight loss, hand-foot skin reaction, alopecia, anorexia, and voice changes. Ecuador requires a strategy for integral attention of cancer that allows for comprehensive, cost-effective, timely interventions in all levels of attention, with the aim of emphasizing actions towards prevention and control, expecting a decrease in avoidable burden and premature mortality generated by cancer. Concluding, many people with hepatocellular carcinoma have no symptoms until the disease becomes advanced. It's better to detect this disease early so it can be properly treated.
Hepatocellular carcinoma is a primary cancer of the liver. It's a cancer that develops primarily in patients who have liver cirrhosis. It's the third most common cancer in the world and one of the leading causes of cancer deaths. The reason it develops is because when patients become cirrhotic, their livers become nodular and inflamed, and tumors develop in these inflamed nodules. The major cause for hepatocellular carcinoma has been hepatitis C, which has been one of the leading causes of cirrhosis. But more recently, we're seeing increasing numbers of patients with hepatocellular carcinoma who have fatty liver disease and have fibrosis, not just cirrhosis. So any inflammation in the liver can cause these tumors to develop. For most patients with hepatocellular carcinoma that present to our center, we evaluate them for liver transplant if they come in in the setting of cirrhosis. The other option is surgical resection or cutting the tumor out. And for those patients who are not suitable for transplant for one reason or the other, they may be suitable for a resection. Not everybody is suitable for resection, and it depends how bad the liver disease is, clearly. And the third modality is treatment from the interventional radiologist with either wires that go into the tumor and burn them from the inside with chemotherapy, or burn them from the outside through wires that come into the liver from the outside. All of these can be combined to get the best results for the patient. The advantage we have at New York Presbyterian for treating such a challenging disease is that the surgeons here are capable of resecting and transplanting the livers. And we have experts in interventional radiology at treating these tumors. When you have a multidisciplinary team that's composed of surgeons who do research on the disease, who can cut the liver out or can transplant the liver, as well as hepatologists who are invested in researching the disease, and oncologists and radiologists, you get a better result for the patient overall. And the patient is directed towards the most appropriate care rather than being filtered into what the center is an expert at. We're an expert at all three modalities of treatment rather than just the one.